Our next session is on approach to chest pain. I'd like to welcome the speaker, Dr. Deepak Davidson, Chief Interventional Cardiologist from Caritas, and chairpersons Dr. V.L. Jayaprakash, Emeritus Professor of Kottayam Medical College, and Dr. Praveen Jain, Interventional Cardiologist, Bharat Hospital.
Especially a patient presenting with chest pain, if the diagnosis is not correct, it can be fatal. So no need to introduce the speaker.
Okay. Respected teachers, today's basically speaker, everybody knows about Deepak sir. Deepak sir is the senior consultant cardiologist in Caritas Hospital. He is well versed with all the major cardiac procedures. So, respected sir, today we would like to listen to how to evaluate chest pain in our clinical practice. So, Deepak sir.
Good morning to all of you. Thank you, GP sir and Praveen. First of all, let me take this opportunity to thank KIMS Academics as well as Dr. Sadak for the opportunity given. Over the next 20 minutes, I shall share with you. Can you please switch off this light also? Something on chest pain and approach to chest pain evaluation. Well, why is chest pain evaluation very important? As JP sir has mentioned, it could be a cardinal manifestation of a life-threatening illness. It could be a very distressing manifestation of a very trivial illness like osteochondritis. So this life-threatening illness one shouldn't be missing. It could be a myocardial infarction, it could be a pulmonary embolism, it could be a pneumothorax, it could be aortic dissection. And so in these subset of patients, once we miss the diagnosis, this could cost the life of the patient. So that's the reason why evaluation of chest pain is extremely important. Now, what are the common causes of chest pain? One, it could be cardiac or it could be non-cardiac. If it's cardiac, it could be coronary or it could be non-coronary. Now, this was the ECG of a patient who was admitted with chest pain. He was a smoker. And how do we diagnose myocardial infarction in this particular patient? You could see that there is ST elevation in lead 2. You could see that there is ST elevation in AVF and 3. So you have ST elevation in 2, 3 and AVF. You tend to see some ST depression in lead 1 and AVF. So you have significant ST elevation in the inferior leads, which makes us understand that this is an infuvol myocardial infarction. Now, this was another patient who presented with chest pain. He's a smoker, diabetic. He had chest pain while at home for 3 minutes. In the casualty, he did not have chest pain, and this was the ECG taken. You could see that it's a normal ECG. Now, is he fit enough to be discharged? He had chest pain. Primarily, he's a diabetic smoker. He had chest pain at home. It lasted for 30 minutes. Presently, he's comfortable. No ECG changes. Now, what would you do? Would you send him home? Ideally, it's to be kept in mind that you need to have a troponin evaluation at the end of 6 hours. And if troponin is positive, then one needs to consider this as having, this particular patient as having an acute coronary syndrome. If troponin is negative, it's always safe to repeat the troponin value at 12 hours, provided this particular patient has multiple risk factors. Now, we know that this particular person is a smoker, diabetic. He has risk factors for developing coronary artery disease. Now, if you feel that this symptom is going to be significant, then a troponin at the end of 6 hours may not be enough. If it's normal, you need to keep him in the casualty. You need to at least admit him for 12 hours, repeat a troponin, and if this turns out to be negative, then probably you could say that this is less likely to be coronary artery disease, and it's also good to have a treadmill evaluation done at some point of time for this particular patient. Now, this particular patient, despite ECG being normal, not having chest pain, he had a repeat troponin at the end of 12 hours. It turned out to be positive, and when an angiography was done, you could see that this is the circumflex artery. There is a tight stenosis in the circumflex artery, and he underwent angioplasty for the same. Well, what are the situations where myocardial infarction could be missed in electrocardiogram? We know that when we have a significant ST elevation in the electrocardiogram, it's easy for us to make a diagnosis. Well, this was a patient who was admitted with chest pain of 30 minutes duration. He was a diabetic. You tend to, if you go through the ECG, you can see that there is no significant ST elevation in most of the leads, but you tend to see that there is some ST depression in V1, V2, and V3. There is ST depression. So we tend to diagnose that this is likely to be an unstable angina. Well, we also had an echocardiographic evaluation done while the patient was in casualty. This is actually the anterior wall of the left ventricle. You could see that the anterior wall is contracting well, but if you look at the posterior wall, this is the posterior wall of the left ventricle, you could see that this particular area is not contracting well compared to all the other areas. So one could suspect that this could be a posterior wall myocardial infarction, and you could also have posterior leads electrocardiogram taken. Now you could see that in V7, V8 and all, you tend to see that there is ST elevation. These are the posterior leads. You tend to see that there is ST elevation. So you could make a diagnosis of posterior wall MI based on this ECG as well as based on the echocardiographic finding. He underwent an angiographic evaluation. You could see that his circumflex artery is totally occluded. That's the area of the circumflex artery. It's totally occluded. Underwent angioplasty and that vessel is opened up. So a posterior wall MI, an isolated posterior wall myocardial infarction, could be misdiagnosed as having unstable angina. Now this was the ECG of the particular patient after 3 days. Well, this is another patient, 64-year-old patient admitted with chest pain and hypotension. You could see that there is no significant ST elevation in most of the leads, but in lead V1 alone you could see that there is some amount of ST elevation. But usually for making a diagnosis of myocardial infarction, you need to have at least ST elevation 2 leads. So here you see that there is ST elevation in only 1 leads. Still that is important. You need to have a troponin evaluation. But what could be the diagnosis when you have an ST elevation in V1 alone, patient is in hypotension? You could also evaluate the right-sided leads. If you concentrate on this right-sided leads, V4R, you could see that there is ST elevation in that particular lead, which makes us understand that this particular patient is likely to have a right ventricular infarction. When echocardiogram was done, this is the left ventricle and left atrium, this is the right ventricle and right atrium. You could see that normally the right ventricle should be smaller than the left ventricle. Here you could see that the right ventricle is ballooned out compared to the left ventricle. So based on this, you could suspect that this could be a right ventricular infarction. And in V4R, if you have significant ST elevation, that clinches the diagnosis. So when you see just ST elevation in V1 alone, this could be an indicator that this particular patient is having an isolated right ventricular infarction. And when an angiography was done, you could see that it's a small right coronary artery and it is totally occluded. So we managed this particular patient conservatively. We did not have to go ahead with an angioplasty because it was a right ventricular infarction. He was managed with dual antiplatelets, anticoagulants, lot of fluids, and he settled down with that. And on discharge, the electrocardiogram was much better. Well, this is another patient who is a hypertensive who was admitted with angina and sweating. You could see that the QRS complex is wide, and this ECG, this QRS complex being wide, suggests that he's got a left bundle branch block. Now, how do we diagnose myocardial infarction when somebody's got a left bundle branch block? Because many times you do an ECG, many times in a patient with LBBB, you tend to see ST elevation in V1, V2, V3. So you are always confused whether this particular patient has got an associated myocardial infarction, associated anti-wall myocardial infarction or not. So the easy way of identifying that is, if you look at the lateral leads, if you look at lead 1 and AVL, there is ST elevation. Moreover, you can see that in the lateral leads, V5 and V6 also you have ST elevation. In an isolated left bundle branch block, you wouldn't be seeing ST elevation in the lateral leads. Many times, this is how the ECG would look like in the lateral leads when you have an isolated left bundle branch block. You could see that there is ST depression and T inversion in lateral leads. Now, when you have ST elevation in the lateral leads also, that goes in favor of a anti-wall myocardial infarction. This particular patient underwent an angiographic evaluation. The left anterior descending artery was occluded and it was opened up, and he had a reasonably good outcome. So just to highlight the fact that every LBBB may not be an anti-wall myocardial infarction. A patient with typical chest pain, sweating, multiple risk factors, you see an LBBB, always watch carefully whether he's got an additional myocardial infarction or not. Now, this is another patient, 52-year-old, chest pain, and he was in cardiogenic shock. you do not see significant ST elevation in most of the leads, but then what is alarming over here is you tend to see lot of ST depression in most of the leads, in lead 1 AVL, in lead 2, 3 AVF, and in V1, V2, V3, V4, almost all the leads you tend to see significant ST depression. And you also see significant ST elevation in just AVR alone. This is the most dangerous electrocardiogram one could have when somebody's got a coronary artery disease. Basically, this particular patient has got global ischemia. That is what you would identify from this particular ECG, and that was the reason why he was in cardiogenic shock. You tend to see ST depression in almost all the leads, and you tend to see ST elevation in AVR alone. And when we did an echocardiogram, you could see that almost all areas of the ventricle, that's the anterior wall, septum, the lateral wall, almost all the areas of the ventricle was not contracting at all. And when he was taken to the cath lab, we found out that the left main coronary artery was totally occluded. So the left anterior descending artery was not perfused, the circumflex was not perfused, just to highlight the fact that it was global ischemia. And when we see an ECG something like this, lot of ST depression, just ST elevation in AVR alone, this is the most dangerous patient, and he needs to be immediately referred for further evaluation and probably a coronary artery bypass surgery. Now, what are the situations wherein we tend to misdiagnose myocardial infarction based on ECG when they do not have myocardial infarction? This was an young chap, left-sided chest pain, no significant risk factors, and a typical chest pain for which he had an ECG evaluation. You tend to see that there is some amount of ST elevation in V1, V2, V3. So when you have somebody who doesn't have multiple risk factors, atypical chest pain, but ECG is something suggestive of ischemia, in those particular situations, straight away do not make a diagnosis of Brugada syndrome. This was a Brugada ECG pattern, but then it's always good to have at least the troponin values done at 6 hours and an echocardiogram if possible to make sure that there is no wall motion abnormality in the anterior wall, just not to miss MI in this particular situation, because you could have these sort of STT changes in patients with myocardial infarction also. So when you see an young man, a typical chest pain, these sort of ECG changes, mostly the diagnosis is going to be a Brugada ECG pattern, but then make sure that there is no evidence, he doesn't have a myocardial infarction, he doesn't have ischemia, by doing a troponin and by doing an echocardiogram to make sure that there is no wall motion abnormality in the anterior wall. Now, this is another patient, a typical chest pain. He was a hypertensive. Just to highlight the fact that the ECG, you could see that there is evidence of significant left ventricular hypertrophy, and you could also see that there is some amount of ST elevation in V1 and V2. In every patient with significant left ventricular hypertrophy, you tend to see these sort of ST elevation in V1 and V2. Mostly make sure that, keep in mind that when you have these sort of ST elevation in V1 and V2 in severe left ventricular hypertrophy, this is a repolarization pattern, and you don't have to be worried about this, and you wouldn't have to make a diagnosis of myocardial infarction based on this ECG. Well, this is another patient, a 35-year-old smoker who had a left-sided chest pain, and this was the ECG done. You could see that there is some amount of ST elevation in V4, V5, V6, and he underwent thrombolytic therapy, and he was referred to us. When we evaluated him, the troponin was negative. Even though he had undergone thrombolytic therapy, his troponins were negative. So this particular ECG, you have a heart rate of around 60. Relative bradycardia, you tend to see an upsloping ST elevation, and you also see some J waves over there. It's more in favor of an early repolarization syndrome. So when you have an ECG something like this, you have a J wave, you have a concave upward ST elevation. This goes more in favor of a early repolarization syndrome. However, as I mentioned earlier, it's always good when you think that there is an ST elevation in certain leads, do an echocardiogram if possible, see whether that particular territory is moving or not. If that particular territory is not moving, then it's ischemia. If that particular territory, if wall motion abnormality is present, then you tend to think that it's ischemia. If there is no wall motion abnormality, you understand that it's less likely to be ischemia. Moreover, because he's a smoker, also have a troponin done at least at the end of 6 hours before making a diagnosis of non-cardiac chest pain and before making a diagnosis of early repolarization syndrome. Just to highlight the fact that in early repolarization syndrome, you tend to see this sort of bradycardia, a J wave, and you tend to see an ST elevation in the lateral leads, which is usually a concave upward ST elevation. Now, this was a patient who presented with syncope and chest pain, syncope and headache in the casualty. That was the ECG taken for this particular patient while in the casualty on a busy day, and it was shown to the resident. The patient was initiated on aspirin, clopidogrel and heparin, and patient became further unconscious after 2 hours. CT revealed a subarachnoid hemorrhage. So just to highlight the fact that history taking is extremely important. Syncope and headache, it was not angina. You tend to see these sort of giant T inversions in patients with intracerebral bleed or subarachnoid hemorrhage. However, this could be also part of stress related T inversions, but when you see this sort of T inversions, always keep in mind that this could be ischemia. However, make sure that this is not ischemia related by further evaluating the troponins echocardiogram could also help you to make a diagnosis, but then history taking is extremely important in these sort of situations. And very rarely we tend to see surprises. This particular boy was an young boy seen long ago in our OPD. He presented with chest pain. It was not given a lot of importance, but then he continued to have chest pain. Because of that, he underwent an echocardiographic evaluation, and echocardiogram revealed that he had severe left ventricular dysfunction. And later on, he underwent an angiogram. You could see that there is aneurysm in the coronaries, there is stenosis in the coronary. Primarily, it was a Kawasaki disease, and later on, he underwent bypass surgery, and we lost him. Now, what are the other causes of chest pain other than myocardial infarction? It could be a non-coronary cardiac cause of chest pain. It could be musculoskeletal, pulmonary, esophageal, vascular, and rarely it could be psychological chest pain also. This is a 70-year-old patient who was in the surgical ICU, had breathlessness, had some chest pain, and this was the ECG taken. You could see that in the ECG, there is some amount of ST elevation in V1, V2, V3. The T waves are inverted. It looks as if this particular patient has got an anterior wall myocardial infarction. Troponin was done. Troponin was just positive. It was mildly positive, but then if it were to be an anterior wall myocardial infarction, you would expect significant amount of elevation of troponin, but then there was ECG suggestive of an anterior wall myocardial infarction. Troponin was borderline positive. Patient was in surgical ICU, and the clinical history probably should make us alert that this could be a Takotsubo cardiomyopathy. This could be a stress cardiomyopathy. Echocardiogram when done, you could see that there is hypokinesia, that is, this is the apical region, this is the basal part of the heart. You could see that the basal part of the heart is contracting well, however the apex is not contracting well, the apex is looking like a balloon, it's a little bit ballooned out. So this is in favor of a stress cardiomyopathy or a Takotsubo cardiomyopathy. Later on, this patient for evaluation also underwent a coronary angiogram which revealed a normal coronary. So just to highlight the fact that when you have a patient who is admitted in the ICU, if you tend to have chest pain, breathlessness, troponin borderline positive with ECG evidence of myocardial infarction, echocardiogram could make us diagnose that this could be a Takotsubo cardiomyopathy or a stress cardiomyopathy. This is primarily apical ballooning seen in the angiogram. The basal part of the heart is contracting well. This apex, it's balloons. That's why you call it a stress cardiomyopathy. Primarily, again, the Takotsubo, it's something similar to a Japanese strap. When you do an LV angiogram, the LV apex looks like a octopus strap. That's why you call it as Takotsubo cardiomyopathy or stress cardiomyopathy. Now, this particular patient was managed conservatively, and the echocardiogram became normal at the end of 7 days. And at discharge, the ECG also was normal. So it's this particular stress cardiomyopathy is being more and more recognized in the ICU. In the past, when angiography was not routinely available, we all consider these patients that have myocardial infarction. We used to treat them with aspirin, clopidogrel for long duration. Nowadays, when more and more of angiogram is being done, you tend to see that this particular patient, they tend to have normal coronaries, and in retrospect, at least you tend to make a diagnosis of Takotsubo cardiomyopathy. Well, this was an alcoholic who was admitted with chest pain. You could see that there is ST elevation in V1, lead 1 AVL. You could see that there is ST elevation in 2, 3 and AVF. You could also see that there is ST elevation in V4, V5, V6. You could see that there is ST elevation in majority of the leads. There is no significant ST depression. So you tend to see non-territorial ST elevations. And when echocardiogram was done, you could see that he's got a significant amount of pericardial collection around the heart. So he was an alcoholic. He had a pericardial collection. So the diagnosis of pericarditis was made. When liver was screened, you could see that there is a liver abscess also. That's a liver abscess which is communicating into the pericardium, and that was the reason why he had chest pain. That was the reason why he had ST lesions. So it is primarily a case of pericarditis. Now, in pericarditis, you tend to see non-territorial STT changes. You tend to see ST elevation in most of the leads, and you tend to see PR segment depression also. So when you see this sort of PR segment depression, probably one should think in terms of pericarditis in these subset of patients. You could have mild elevation of troponin in patients with pericarditis also when you have some myocardial involvement also. This is another electrocardiogram of a 24-year-old smoker who presented with chest pain. You could again see that the ECG is looking similar to the previous ECG. You tend to see ST elevation in lead 1 AVL, you tend to see ST elevation in lead 2, you tend to see ST elevation in V1, V2. So almost all the leads there is ST elevation. He was a smoker. When we did the echocardiogram, we made out that there was a mild pericardial effusion for this particular patient. He was managed conservatively, hoping that it was a viral pericarditis. He did well. He came back with a repeat episode of pericarditis almost 3 months back. Again, after 3 months, he came with a repeat episode of pericarditis. This time he was further aggressively evaluated. ANA was positive. His anti-Rho, anti-LAB and antibodies were positive. So it was primarily a case of mixed connective tissue disorder which presented with pericarditis. Well, this was another young chap who presented with atypical chest pain. You tend to see there is some ST inversion in this particular lateral leads. However, this particular T inversions were considered at that point of time as non-specific. It was told to him that you do not have any cardiac involvement. He in fact underwent a treadmill evaluation also for this sort of T inversions, and treadmill also turned out to be positive. However, a few days later he presented with these sort of small gangrenous changes on his toes. So this time it was evaluated and he had some abnormality in the Doppler. So he underwent an angiographic evaluation of the peripheral arteries, and when the angiographic evaluation of peripheral vasculature was done, he also underwent an evaluation of the coronaries because of the T inversions, and you could see that there is some luminal shadows inside the right coronary artery that was suggestive of a healed thrombus. So he had some thrombosis of the coronary artery, that was the right coronary artery. This was the left anterior descending artery. Again, in the left distal anterior descending artery also there was evidence of thrombosis. So he was further evaluated and we made out that his platelet count was 6.6 lakhs, and this platelet count was the reason why he had thrombosis of all these vessels, and presently he is under the treatment of Dr. Unni. He is doing well for the last 4 years. Now, chest pain other than myocardial infarction, it could be non-coronary cardiac, it could be musculoskeletal, or it could be traumatic. Regarding musculoskeletal, it could be cervical disc disease, it could be costochondritis, fibrositis, herpes zoster before the rash, neuropathic pain, rib fracture. There could be a lot of reasons why you could have chest pain related to musculoskeletal causes, and even trauma to the chest also can lead on to chest pain. This was a patient who had a road traffic accident 3 months ago, now presented to have nagging chest pain, mild discomfort for the last 3 months. He underwent a CT angiogram, and a CT angiogram cleans the diagnosis. He had a aneurysm in the descending thoracic aorta. You could see that there is an aneurysm, that's an outpouching in the descending thoracic aorta at that particular age, which can at particular area, it can be clearly made out over here. So finally he underwent a stent implantation over there. That was an endovascular stent implantation being done. The stent position there, you are seeing the aneurysm there, and that's the result after the stent was implanted. Well, you could have pulmonary reasons for chest pain. It could be pleuritis related, it could be pneumonia, it could be pulmonary embolism, or it could even be related to tension pneumothorax. This was a patient, an obese lady who presented with chest pain, dyspnea, her troponin was positive. So our resident made a diagnosis of acute coronary syndrome. You could see that there is T inversion in lead 2 and lead 2, 3 and AVF. So inferior leads, you could see T inversion. The troponin was positive and was made, and a diagnosis of acute coronary syndrome was made and was initiated on heparin. Now, when echocardiogram was done, you could see that the right atrium and right ventricle was significantly dilated. So when you see a patient with dilated right atrium, right ventricle, with breathlessness, always think in terms of pulmonary embolism. When you have a moderate or a severe pulmonary embolism, massive pulmonary embolism, the right atrium and right ventricle, it immediately dilates, it balloons out. So based on this particular finding, we have diagnosed many pulmonary embolism, because ECG you may not be able to clearly pick it up, but when you do an echocardiogram, if you see that the right atrium and right ventricle is dilated, always think in terms of pulmonary embolism. Go ahead with a CT angiogram to evaluate for pulmonary embolism. So after seeing this echocardiogram, the ECG was further evaluated. Now you could see that there is S1, Q3 and T3, which is more in favor of a pulmonary embolism. So you could have these sort of T inversions in anterior leads V1 to V6 in pulmonary embolism. You could have something very specific, S1, Q3, T3 in pulmonary embolism. So just to highlight the fact, the message is when somebody comes with breathlessness and chest pain, you tend to see these sort of T inversions. Troponin positive. Troponin also can be positive because of the right ventricular strain. You could have a troponin positivity. Always having an echo will clinch the diagnosis, will make you suspect that this is likely to be a pulmonary embolism. Well, we had a pulmonary angiogram also done for this particular patient. You could see that there is huge amount of clot sitting inside the pulmonary artery, which can be appreciated in this frozen image. Patient underwent thrombolytic therapy for 48 hours, and you could see that the entire clots have disappeared. So these are the pre and post procedure images. You could see that the clot sitting there, and this is following thrombolytic therapy. It's totally disappeared. This is another patient who presented with chest pain. You could see that there is ST elevation in V1, V2, V3. He had atrial fibrillation also, was taken to the cath lab. In the cath lab, we found out that the left anterior descending artery was totally occluded. We did an angioplasty for that, but we also made out something interesting. You could see in the lung fields, it was the lung shadows were not seen in the lung fields at all. So we could also identify it was an antival myocardial infarction patient. Also he was a COPD patient. He also had cough and pulmonary edema. Because of the cough, he also had a pneumothorax, tension pneumothorax. So that too was identified, and he had a primary angioplasty and a ICD also implanted at that point of time. Now, regarding gastroenterology causes for chest pain, it could be GERD, gastritis, peptic ulcer, gallbladder disease, and very rarely, one shouldn't miss this particular situation. This was a 64-year-old gentleman who developed vomiting and severe chest pain. Immediately after a heavy meal, he collapsed. He was taken to the ER. Finally, a diagnosis was made. He had an esophageal rupture. That led to hypotension, shock, and he underwent surgical correction of that. Now, rarely vascular causes of chest pain could be dangerous for certain patient. This was a 74-year-old hypertensive patient with severe chest pain. You could see that there is ST elevation in lead 2, 3, and AVF. So that makes a diagnosis of inferior wall myocardial infarction. You could see that ST elevation is seen in lead 2, 3, and AVF. So that is inferior wall myocardial infarction. This particular patient was taken to the cath lab, and we diagnosed that it was a aortic dissection. You could see that 2 minutes. So this was a case of aortic dissection. What happened was he had a dissection involving the ascending aorta, and that's the flap seen there. You could see it in this particular image. The flap was actually extending into the right coronary artery, and that was the reason why this particular patient had an inferior wall myocardial infarction. Echocardiogram was done. There was a flap sitting inside the aorta. So I'll skip those slides and come to the last few slides. So diagnosis of aortic dissection could be easily made out with echocardiogram, provided you suspect the aortic dissection. That's the descending thoracic aorta. You have a dissection flap sitting there, and the diagnosis finally can be clinched with the help of a CT angiogram. Now, what's our job while evaluating chest pain? Identify life-threatening problems, appropriate urgent management of life-threatening problems, avoid overdiagnosis and overworkup, and avoid inadvertent discharges. So these are probably the reasons that shouldn't be missed for a chest pain. Probably if you miss these diagnoses, probably we might lose the patient. Once again, thanking Dr. Sadak for the opportunity given. Thank you very much.
Thank you, sir. Inviting Dr. V.L. Jayaprakash to give a memento to Dr. Deepak Davidson, and Dr. Shobana Devi Madam to give a memento to Dr. V.L. Jayaprakash and Dr. Praveen.
Thank you all. Let us, I think we are proceeding for the inaugural session, and so we will have Okay. So some questions can be, Dr. Deepak has done a very elaborate coverage of all the topics with chest pain, and let us go for some queries. Sarma sir.
Thank you, Deepak, for the nice discussion. Just one point. You said you are highlighting the clinical scenario and history, very important, because patient subarachnoid hemorrhage is missed because of the giant TV inversion. Similarly, in dissection also, you have seen the last slide is on dissection. We had a patient about 6 months back. Patient came with central chest pain, evaluated in cardiology, emergency medicine, and admitted in Department of Medicine for 3-4 days. And they didn't take the proper history. History revealed the central chest pain, interscapular pain radiating downwards. So it is very typical. Angiogram was done, showed a typical dissection beyond left subclavian going down like this. Fortunately, celiac artery, nothing was involved and came to the right common iliac. And the patient is subject to surgery. So this can happen. So your clinical history is very, very important. And also it is important to take the BP in both upper limbs, sometimes preferably in the lower limbs also. So that we may not miss such a dangerous condition. If you give aspirin to the patient with a dissection, what can happen? Aspirin. No, usually give aspirin clopidogrel. So I think the bleeding will continue. Number 2, the books highlight the D-dimer, dissection versus coronary. Can we just comment on that? D-dimer. A few months back, I had in a conference, I came across this D-dimer will be useful. Recently also I read somewhere that D-dimer will be useful in a certain situations to distinguish between dissection and coronary artery involvement.
See, in coronary, usually we don't get a D-dimer elevation to a significant extent. Coronary says D-dimer elevation is not very to the significant extent. So if the D-dimer is elevated, you have to think on other conditions, especially pulmonary embolism or other thrombotic conditions or dissection. There can be clot formation in dissection, especially.
Yes, sir. So when you have a ascending aortic dissection and when it extends into the coronary artery, thrombolizing is disastrous. But many times aspirin clopidogrel may not really worsen the scenario. And sir, as you mentioned, when thrombus formation occurs, definitely D-dimer has to be elevated, but it never happens in an acute coronary syndrome.
Thank you, sir, for highlighting all the points. Especially history is very important. Each part is important. It has to be an integrated evaluation in a chest pain. Otherwise, we will miss. History may be only the clue. Everything may be normal. Examination may be a very important thing. Especially, I had seen pericarditis with ST elevation being taken for primary angioplasty without auscultation, but there was extensive pericardial rub. ECG may be non-diagnostic. ECG may be normal. Many situations where with one ECG patient was sent and dying on the way. Echo can be misleading. Whenever we see ECG changes, we will tend to think there is RWMA, or echo can be even normal. Even angiogram can be normal because we have MINOCA, that is myocardial infarction with the normal coronary artery. So it has to be integrated evaluation starting right from the chest pain up to the angiogram.
Regarding this early repolarization, is there any lead specific that is showing this ST, that is repolarization is more dangerous than the anterior types?
Yes, sir. There are 4 types of early repolarization here as type 1, 2, 3, 4. The type 1 is the innocuous one seen in young people with mid-precordial leads only showing a V2, V3, V4. Usually seen along with bradycardia, innocuous. Whereas the type 2, 3 and 4 we have to be cautious. Type 2 means it is in the infralateral leads, ST elevation is there. That has a slight tendency for VT and VF and sudden death. And type 3 is the one which is more dangerous. We have type 3 and 4. Type 3 is global ST elevation. There is ERS in all the leads, including sometimes right-sided leads. That is the most dangerous, higher chance of SCD. And type 4 is our Brugada. So type 3 and type 4 has to be cautious.
Sharma sir, I think one point I would like to say is that if the D-dimer, if you are suspecting a case of aortic dissection, and the D-dimer is negative, then you can safely rule out dissection. So it has got a negative predictive value rather than a positive value. Thank you, Deepak sir.
Thank you.
Any other question or anything? Because
Thank you so much, sir.
thank you. I think let us give a big clap to Deepak for having an extensive coverage.
Inviting Dr. V.L. Jayaprakash to present a memento to Dr. Deepak Davidson. I'd like to welcome Dr. Shobana Devi, HOD of Gastroenterology, to present a memento to Dr. V.L. Jayaprakash and Dr. Praveen Jain.